Okay, thanks everyone for coming so bright and early. My name is Kristen Park. I'm one of the epilepsy docs at the Children's Hospital of Colorado and involved in the neurogenetics clinic there. And this is my colleague, Katie Angione, one of the genetic counselors in the neurology department. And we were asked today to speak about genetic epilepsies, testing and treating them. So we have a lot of ground to cover, so we thought we would get started right away so that we can leave some time at the end for questions. So, we'll start first with a question about why do we do genetic testing in epilepsy. And so this is just some background about the epidemiology of epilepsy. It affects about 65 million people worldwide, and 25% of them are children who are less than 15 years of age. I put a graph there. The incidence is highest in children in the first year of life, and then kind of a second peak in the elderly, typically due to stroke. And the cause, unfortunately, remains unknown in about a third, up to 2/3 of patients, depending on the study that you look at. About 25% of patients do have a structural etiology, so they had a stroke, they have a low-grade tumor, there's a malformation in their brain, and those are relatively well known. But in the absence of that, I think that's when we think of genetics. Often genetic epilepsy or epilepsy in general is associated with other additional neurologic issues, so intellectual disability in a fair number of people, and autism spectrum in about 15%, especially again in that younger cohort of children where epilepsy begins in infancy. There are specific epilepsy syndromes that are often genetic in etiology. Again, many of the severe catastrophic epilepsies that begin in infancy, West syndrome, Ohtahara syndrome, Lennox-Gastaut, and Deuce syndrome, they only make up about 10% of epilepsies, but they are often genetic. Juvenile myoclonic epilepsy, on the other hand, is a more common epilepsy. About 10% of people in the epilepsy community have that diagnosis. So how does that kind of relate to epilepsy genetics? And the issue is that most of the studies that talk about the epidemiology of epilepsy were done probably back in the 90s, even earlier, and that's when we didn't have a lot of information about the rates of epilepsy and the same methods of genetic testing that we do now. We know that genetic causes are more likely in early onset epilepsies, and they can be identified more easily in epilepsies that are more severe and those that have additional comorbidities. And that's because those genetic effects are typically larger because they've manifested so early and with such severe symptoms that they're a bit easier to pick out from the genetic backdrop of the variability among all of us in our genetic makeup. So I've put some pictures up here to kind of, I think this one got kind of, no, it's just small. So I've highlighted this picture. So this is kind of the effect size. This would be our genetic backdrop, and then this would be environmental factors. And you can see that in monogenic causes of epilepsy, so epilepsy that's caused by one gene, the gene effect size is quite large, and environmental influence and the variability between people is a bit smaller. Whereas when there are lots of different risk factors, the effect size of the gene is quite small, and there are a lot of other things that modify whether people will manifest seizures. And so most gene discovery to date has been in this category, in monogenic causes of epilepsy in more severely affected children. There were a lot of families, so a lot of our initial genetic testing studies were done in large families from Sweden, from Australia, from Finland, where they had a lot of people who were affected by epilepsy in that family, and they were able to link genetic causes to those affected family members. But then when they tried to take that into a clinic and say, Utah or even, the UK or somewhere else, they really weren't able to translate that into the general population. Those things seem to be unique to those families. They've done a few larger studies, what's called genome-wide association studies, and the initial ones were negative. Just recently, I've highlighted here, they did a much larger study that looked at 17,000 participants. 8,000 of them had epilepsy, and then also controls. They identified one gene in that study. And that's how many people are needed to do epilepsy genetics in these types of genes, where there's a lot of variability and we need to pick that out from the backdrop. They just finished another one, the International League Against Epilepsy, the ILAE, sponsored another study involving 15,000 patients with epilepsy and then 29,000 controls. This time we were able to identify 21 candidate genes. I think, though, the encouraging thing about this is that there is a lot of emerging evidence that there is variability in some common pathways, so that even though we need these large numbers, some of the same genes are involved in severe epilepsy in childhood that are also involved in more common epilepsies in older people. And then I'd like to finally talk about, again, in this category, something called polygenic causes or complex inheritance. And that's the concept that one gene doesn't cause epilepsy, that it's probably in those kind of more common forms, it may actually be the sum or the additive effects of several different variants in several different genes that combine together, and that's this graph here. So this is liability, so tendency to have seizures. And then once you cross kind of a certain threshold, like a seizure threshold, that's when you begin to manifest the symptoms. So you have to add up a number of different gene effects until you get to this point. And so that's the concept of polygenic inheritance or polygenic epilepsy. And I think that is potentially what many of the more common epilepsies where people are less severely affected, what's going on there is probably in that category. So just to kind of branch out a little bit, this is a graph of the epilepsy genes that we've discovered so far. You can see we started off kind of slow back in 1995 with autosomal dominant frontal lobe epilepsy, followed by SCN1A, which is associated with Dravet syndrome. And then since that time, it's just been an explosion of epilepsy genes that we have learned about. So the question that we asked is, why do we do genetic testing? And I think that there are a lot of questions that can be answered with that. So we've kind of put a few up here. Recurrence risk, so will anybody else in the family be affected by epilepsy? Prognosis, is the epilepsy going to go away? Are there other medical issues that may be associated with the epilepsy? Treatment, is there a specific medication or therapy that should be tried? And that's really the ultimate goal for understanding the cause of epilepsy, what we call precision medicine, so the ability to take a targeted treatment directed exactly at the cause of someone's epilepsy, and we'll talk about that at the end. And then finally, this diagnostic odyssey. So there are a lot of children with severe epilepsy who have had many, many tests, and nobody can explain to them why their child has epilepsy. And getting an answer to that question can be really, really transformative for families. So just to expand on those things a little bit, so recurrence risk, most data suggests that in common epilepsies, the risk to having a first-degree affected relative is about 8 to 10% based on the epilepsy syndrome. But genetic diagnoses could really refine that number, and it could be higher, it could be lower, and so it's important to have that information when thinking about family planning. Prognosis is hard to provide for an individual patient. Even a genetic diagnosis has a very wide range of outcomes. But I think it's important to exclude degenerative conditions or to kind of give someone that range. What is that range and where do you fall potentially within it? And then finally, treatment. So about 40% of people who get a genetic diagnosis will get a change in their management because we may know that one medication is not as good as another for this particular syndrome, or there is a report of something that's more effective that can be used, or again, we do additional screening testing. And so that, I think, is a very important reason to do testing. And then finally, this concept of diagnostic odyssey. So I just put a statement up there that prior to the testing strategies that we have now, families employed low-yield, expensive tests to narrow kind of a long list of possible causes for epilepsy, especially in children. And that took quite some time and often cost over $10,000 per patient. And on average, it took about 5 years before people would get the correct diagnosis. And I took some quotes here from some patient families who have kind of reached the end of that odyssey. And one of them, I feel all of them are pretty powerful. The first one was that the limbo of researching, speculating, trying medications, and jumping from specialist to specialist is physically and emotionally exhausting. And so hopefully getting an answer can sometimes end that journey. So next I'd like to bring up Katie to talk about how we do genetic testing, and we'll keep alternating here.
All right. So when we decide that we want to do testing for a patient, that it's appropriate, our next question is, how do we go about doing that? So there's a lot of different types of genetic testing out there. I'm not going to go into every one of them today, but if you want to come up and chat afterwards, we can certainly talk more about the ins and outs of all this different testing. I think for most patients with epilepsy, some of the most common tests that they might be getting in today's landscape of genetic testing are chromosomal microarray, next generation sequencing panels, usually targeted specifically to epilepsy genes, and whole exome sequencing, although there's a lot of other testing in between that. Next generation sequencing is a technology that's used to obtain large amounts of sequence data in a relatively quick and cost-effective way. We're looking at many different genes at once, and as genetic testing and knowledge of genes has improved over time, those panels are kind of consistently growing and changing and evolving as we learn more. This allows us to look at a lot of genes at once, as opposed to sort of the old method of looking at one gene at a time. And this is really good for conditions like epilepsy that have a lot of kind of similar features in patients who might have epilepsy caused by many different genes. The turnaround for these panels is usually around 4 to 6 weeks at this point, but it can be anywhere from 2 weeks up to a couple of months, depending on how large those panels are. And currently, that technology also typically allows for detections of deletions and duplications in those genes, and not just mutations that are more like spelling errors or typos. This can be done on a lot of different sample types. Historically, we were always doing this testing on blood, but it's become easier and easier to get DNA from other samples. So these days, we're often doing this testing on saliva, on cheek swabs, things that can make it a little bit easier for certain patients. There's a few different potential results anytime we do a genetic test. So there's sort of 3 outcomes that we can see. Number 1 is that the testing is negative. It doesn't find a mutation in any of the genes on that panel. That does not rule out a genetic cause. Every single test is only as good as our knowledge at the time that that test is done. So there's always the possibility that there's a more rare cause, something that was not able to be picked up on that panel. It's possible that the testing is positive. That's why we do it. We're hoping for answers. This is when a genetic mutation is identified in a gene that fits what we're seeing in that particular patient, and it's a mutation that we know enough about to say this is for sure impacting how this gene and how this protein is working. Unfortunately, the most common outcome when we do, especially a larger panel, is that we end up with an answer we don't completely understand, often referred to as a variant of uncertain significance. This comes up probably about 85% of the time we send our most commonly sent epilepsy panel. We at least have one variant of uncertain significance to try to understand. So what this actually means is that there's a change in a gene, but there's not enough evidence to determine if that particular change is impacting how that gene works. Every change in a gene, there's thousands of potential changes within every gene. Some of them don't cause any issues. Some of them, even a very small change that's only affecting one letter of the DNA code can cause a really big impact on how that gene and how that protein is working. So part of our job is to try to sort out that uncertainty. So any variant in a gene, a variant is an alteration in the DNA sequence that's different from what's seen in the majority of people. There's sort of some caveats to that. So different from what's seen in the majority of people, all of the databases that we use to compare what's normal or typical versus what could potentially be causing disease, those databases are not perfect. They're often very, very strongly weighted towards Caucasian patients. They don't take into account all of the normal ethnic variation that we can see. So even those databases that we use very commonly do have their limitations. A variant can be benign, meaning that it's not disease-causing, it's normal. Pathogenic, meaning that it does cause disease, or again, those uncertain significance variants. We often refer to pathogenic variants as mutations. That's sort of the common lingo, although we're trying to kind of sway that towards using the term pathogenic variant, but they can be used interchangeably. There's a lot of different types of mutations. There are missense mutations, which we often refer to as typos or spelling changes. That's where there's one letter in the DNA code that's switched out for another letter. And that small change is enough to disrupt how the body encodes that protein that it's making from the gene. A silent mutation is sort of a misnomer. It changes the DNA, but not the protein, so not the amino acid that's building that protein. So the reason that that's possible is because our DNA is sort of a code that tells our body how to build proteins. And proteins are just anything in the body that has a job, helps our body to grow, to develop, to work the way it's supposed to. So that code is redundant. There are 3 letters in the DNA code that are read each time that the body is adding a unit onto that protein. But there are multiple sets of 3 letters that can code for the same part of that protein. So it is possible to change the DNA without changing that unit of the protein. The reason I say that silent is a misnomer is because we know that there are sort of extra levels of complication of our DNA that until recently we haven't understood very well. So there are some families out there and some patients out there who have silent mutations, but those mutations are actually what's causing their epilepsy. And again, I can go into kind of more details if anyone wants to chat afterwards. A nonsense mutation is a change in a DNA base pair that signals the cell to stop building that protein. So it's telling the body, we're done here, we can stop building the protein now, but it's sort of stopped short. It's not done doing what it's supposed to be doing. So that protein gets cut off, and we refer to that as an early truncation or a shortened protein. There's also insertions, deletions, or duplications, where we might add a piece of DNA, remove a piece of DNA, or add an extra piece of DNA. And all of those things are going to throw off that 3-letter at a time reading frame. And that sort of shifts what the body is reading, and it alters the rest of the code afterwards. So those are called frame shift mutations because they're shifting that reading frame. So this is an example of a test report that many of you may have seen before. This one in particular is showing a positive result in an SCN1A gene, which is usually associated with Dravet syndrome. So this is kind of some of the things that you might see on a genetic testing report. That word pathogenic means disease-causing. You might also see benign, which means non-disease causing. There is a sort of letter and number address for where the change is located in the gene. So when you see C dot on your child's testing report, the C stands for coding. That means that this is the change in the coding DNA. So I don't know if you can see up here, but this is saying C1278 C to G. What all of that means is that at the 1,278th position in this particular gene, there is supposed to be a letter C. Instead, there is a letter G. And that one letter change is enough to impact the gene in a way that it causes Dravet syndrome. This part right here, the P stands for protein. So this is the resulting change in the protein because of this change in the DNA code. Again, you can see this TYR, it stands for one of those units of the protein, just one of the different building blocks that are used to make up different proteins. And this is saying that at the 426th position, we're supposed to have this unit called tyrosine, and instead, you see this little star, this means that it ends early. That's what reports often use to indicate an early truncation or a stop. Often we can also see this as an X or a star. There's a lot of different ways to indicate it, but this is just meaning that the protein is stopping short. Usually down here, the next part of the report will show some information about that disorder. I think the thing that we always need to keep in mind is that this is the lab's interpretation. The lab doesn't know your child. The lab doesn't know all of the details. We try as physicians to provide them with enough information to interpret the results well. But once we get the report back, our job is to sort of translate it and to make sense of it, to make sure that it fits our particular patient. So what do we do when we have negative or uncertain results? There's a lot of different things that we might do to sort of take that next step beyond what the lab is able to do. We might do family studies where we test other people in the family to see if they have that same genetic change. Is there anyone out there that's had parental testing done because their child has had a result? Exactly. So that can be really helpful in sort of teasing out, is this just a normal variation in your family, or is it something that's causing seizures in your child? For some genes, family studies can be really helpful in reclassifying things. In other genes, there's a lot of variability between people in the same family. So finding a variant in a father who doesn't have seizures doesn't always mean that it's not causing the seizures in their child. So it can get really complicated and confusing depending on the gene. We also often do functional studies where we're looking to see in a petri dish, does this particular change in that cell, in that neuron or brain cell, is that impacting how it's working? We might consider moving on to more comprehensive testing. So if we've looked at just a handful of genes, we might do a larger panel. If we've done some panels and they haven't given us an answer, we might move on to something like whole exome sequencing. So sometimes there are additional steps to take. And then sometimes we just might need to wait until that particular variant is better understood, or until there's more genes that are identified that are associated with that particular disorder. And then if we have positive results, what we first do is we have a discussion with the family about what that particular diagnosis means for their child and for their family. What can they expect going forward? Are there any specific things that we should do differently because of this diagnosis? We'll help to identify appropriate resources. Often we have great family advocacy groups out there for certain conditions, so we'll definitely always try to get families in touch with those groups, maybe with specific patients that we've seen that have told us, have other families reach out to us. We'll also do some genetic counseling regarding recurrence risks. Is there a chance for parents to have another child with the same condition? Is there a chance that that child will pass down that condition to their own children? And is there a chance that siblings have any risk of developing the same symptoms or having a child themselves with the same condition? We will also consider any gene-specific treatments, if they exist for that particular condition, any studies that might be ongoing, or any clinical trials that are relevant. This is becoming more and more a big driver for doing testing as we start to identify more gene-specific treatments and therapies. And then we'll also refer to other specialists if we need to. There are some epilepsy conditions out there that also involve other parts of the body, the heart, the kidneys, things like that. So we'll get people in touch with the right physicians and the right specialists. So then I'm going to turn back to Dr. Park for the remainder of the talk, and then we'll be here for questions.
All right, so the last thing to talk about, I think, is what to do with those results when you have them. And again, a little bit to talk about treatment. I think it's a bit too broad to talk about specific treatments for each type of epilepsy genetic condition. So what I've tried to do is give kind of a 50,000-foot view of what the landscape looks like for precision therapy the that's kind of where we'll take the talk. So the first thing I'd like to say is that there are a lot of other resources available once there is a genetic diagnosis. Many of these genetic diagnoses are quite common. They have well-developed resources like the Dravet Foundation, but many of them are quite rare, and there may be only a few other people in the world who have such a diagnosis. And so there are, but the internet is a powerful tool, and there are a lot of things that we can offer about where to look for information. And so a number of these are our favorites. The Genetics Home Reference is put on by the National Institutes of Health, and it has a very interactive place where you can put in the name of a gene. It will show you information about how that gene works, what it does in the body. It will show you conditions associated with changes in that gene, and it has a number of hyperlinks in the text that tell you the meaning of terms if you are not aware of what they mean. So if you need to talk about what is a missense mutation, what is a deletion, all those types of things, it will take you to a place that will define those terms. The next thing I placed up there is something called Beyond the Ion Channel, which is a blog, but a very comprehensive discussion about genetics and epilepsy put on by the International League Against Epilepsy and written by Dr. Ingo Helbig out of Children's Hospital of Philadelphia and his wife, Katie Helbig, who is a genetic counselor like our Katie. And so they have a lot of information about different genes that have been discovered in association with epilepsy. The next one is NORD, the National Organization for Rare Diseases. Many of the conditions that we test for are members of that group and have information about treatment and diagnosis of those conditions. And then the last one is Simon's Searchlight, which used to be called Simon's VIP, again, an organization that provides information about a number of rare genetic conditions. The last thing I put up here is that if there are often references associated with the genetic test report that you may get as a result. You may be able to either yourself or your physician reach out to the corresponding author on those papers and say, you know, my child or my patient has this new diagnosis. This is their variant or their mutation. What do you think about that? Is there any research available that you are doing that they could participate in? And we've had very good luck in being part of that. The next thing I would highlight is family organizations and research partnerships. So these are just a number of different family alliances. Many of them started again as grassroots efforts from parents whose children were diagnosed with these very rare genetic epilepsies. Many of them have places to go for information about test results. So is that something that's been seen in other children with that condition, what's called a kind of a registry or a database of particular mutations. They also may have a natural history study ongoing, which is kind of one of the first steps that we'll talk about for precision therapy. And some of them, including this one over here, CFIRV, may do functional testing. So for the GRIN disorders, which is an NMDA receptor, they will do those tests in a dish that will help the doctors to understand, is this variant in one of those genes actually causing a problem for how the gene functions? So, as I said, I think our goal for everyone is what we're calling precision medicine. That's kind of the new buzzword for these genetic diagnoses. And that really means, can we take something aside from kind of the general generic anticonvulsant medication that we use for all people with epilepsy and figure out something specific that's going to work for the person who has potentially a genetic epilepsy? Is there something that we can use that will target the reason that the seizures are happening in that patient and help to correct that error? And so I think in order to accomplish that, there needs to be a large body of knowledge that's available and that's understood about each of these genetic epilepsies before that is possible. And so I've kind of outlined that here. And the first is to characterize the variability in the condition. So not every child with a genetic epilepsy is going to behave exactly the same. If we make a parallel, say, with Down syndrome, trisomy 21. Every child in that condition has an extra copy of that 21st chromosome. And yet many of them, or some of them, will have severe congenital heart disease. Some of them will have epilepsy in infancy and are pretty sick, while others of them are holding down jobs, living relatively independently and pretty healthy. And that's a big variation, and that's all in the same condition. That variability exists in Dravet syndrome. That variability exists in every single condition. And it's part of that graph that I showed earlier. Not only are we talking about changes in one gene that causes the condition, we're talking about the fact that that occurs on the genetic backdrop of each person, which is also very different. And those people have been exposed to different things in their life. So there's a wide spectrum of how that condition presents itself, and you need to understand what that spectrum is before you know how you're going to be able to affect it. The second thing is you need to model the condition to understand how it affects the body. So just because you know that there's a channel that doesn't work, you need to understand how does that cause epilepsy? Where in the brain is that channel expressed? Does it happen when you're a baby and not when you're an adult? Does it cause the brain to be overly excited, or does it put the brakes on things? How does it affect the brain to cause seizures? And that can be done often with animal models and with more complicated cellular models to kind of get a feeling for how things work. The third thing is to have biomarkers. So what are we going to be looking at to assess treatment response? Is there something within the body that we can use as a proxy, or are we going to be counting seizures, or are we going to be looking at some other sort of functional outcome? Finally, targeted drug screening. So there are a lot of programs out there now trying to look at conditions that are having these genetic diagnoses. Can we screen drugs that are already approved by the FDA, that have been through a lot of the hurdles that it takes to get a drug to market? Are any of those going to be effective in these rare genetic epilepsies? Because that circumvents a whole lot of steps that each of these disorders may not have the kind of time or money to do. And then next, doing either an N of 1 or randomized controlled trials. So sometimes there are conditions where somebody has written a case report that has said, hey, we use this particular precision therapy in a child with a genetic epilepsy, and it seemed to do pretty well for them. And so you may want to ask your doctor, is this something that you would be willing to do? The issue with that is that it doesn't get the field very far. It doesn't tell you, again, those bigger questions. Is this going to work for every child with this condition? Are we going to be able to get this drug to market and get it to the other people who need it? It doesn't answer any of those questions. Those questions are all going to be answered with a randomized controlled trial, which is a large group of people, some of whom will get the treatment and some of whom will get placebo. And then again, we will watch to see what those markers, whether they're improving or changing, and whether the children are getting better or not. And then finally, many of these people have gone on to develop partnerships with industry, with other research organizations, and with parent families and patient families who have become really powerful tools in driving this field forward. And so I've highlighted a couple of them here. The CFIRV, which I talked about before, is out of Emory University. It's funded not only by the NIH and the National Institute of Neurologic Disorders and Strokes, but also by family groups. And they have made available this physiologic testing of variants to patients and physicians who identify a potential abnormality in one of these genes. And that's really taken a lot of effort and research power to move that field forward. They are now working on funding a natural history study. They've published one N of 1 trial, and they are now working on progressing to clinical trials. And that's really quite powerful to go from a single genetic diagnosis made only a few years ago to now being able to target that into precision therapy, and much of that was driven by families and patients. I would give you the parallel here of Dravet syndrome, which again is related to changes in the SCN1A gene. That was one of the first genes that was discovered, and again, through people's efforts, they've been able to grant 43 research grants of $4 million to people to now move into phase 3 trials for several medications, specifically targeted towards the treatment of SCN1A-related epilepsy. And they are in preclinical phases with some gene-based therapies, which is, again, something that everybody kind of thinks of as the holy grail for genetic epilepsies. Can we actually correct the problem, not just treat the epilepsy? So with that, we'll close for questions. We've got a good 15, 20 minutes. So anybody? Yeah.
Is there a place on the internet that parents, caregivers can go to be part of these studies? Because I understand you need thousands and thousands of people.
Yeah, so I think those are closed at the moment. They've already been completed. I don't know where they advertise them. Most of the time, trials are advertised, at least in the United States, at clinicaltrials.gov, which is where all research studies have to be registered. So that would be a good place to start, to look for that.
Yeah, and those clinicaltrials.gov will allow you to search for specific types of epilepsy, specific genes, to see if there are specialized trials going on with those particular conditions. And then they'll also tell you about things like exclusion criteria, ages that they're accepting, things like that. So it usually gives a good rundown of the study. Anybody else?
Yeah.
So we had a whole expo done almost 2 years ago. They came back with a genetic variant for epilepsy, and it's very rare. But I've heard that you should go back to the labs and kind of get a reread as they start to get more people. Like, how do you go about doing that? Who should I follow up with?
So I would recommend chatting with the doctor that ordered the original testing. What they can do is just submit to the lab for reanalysis. Depending on the lab, it's usually they'll do the first reanalysis at no additional cost, but it does vary from lab to lab. And they should be able to do that without any extra sample or anything like that. It usually takes a month or two for them to go back over all of the data, but that's where I would start, would be to contact the doctor that ordered the original testing.
Yeah.
My son's doctor is ordering genetic tests now. That was the beginning of your talk. And I just wanted to get information on what genetic tests should I be asking for and what should I expect.
Yeah. So I think which test is kind of dependent upon how the epilepsy presents itself. As Katie said, most testing now is typically what's called a next generation sequencing panel. So it looks at a certain number of genes related to epilepsy and looks for changes in the sequence of those genes, as well as if there are missing or extra parts of those genes, deletions or duplications. And that's typically the first step in most genetic testing if epilepsy is the main presenting symptom in a child. And so I'd say starting with that is probably the best place. And then based on the results, then that would determine whether additional testing was necessary. Next generation sequencing, NGS, and or panel is the other, an epilepsy panel is the other term that's often used. And there are panels put on by lots of different companies. So, some of them have 50 genes, some of them have 120 genes. So it'll be variable what you get, but you're getting the kind of same technology and the same kind of concept that you're looking at a group of genes related to epilepsy in childhood. Yeah. It's okay.
Is there any specific test that you would suggest? I think they're asking for a saliva test.
Mm-hmm.
Let's just do it at home. Is there something more specific that we should be?
So a lot of different labs with different panels have many different options for what type of specimen they use. So most labs can do testing on blood, saliva, cheek swab, whatever the case may be, but that doesn't, so the specimen that they're using doesn't necessarily tell you about what they're testing that specimen for. Whatever they're using, they're always getting the DNA out of that spit sample, that blood sample, and then they're going from there. So It matters more which lab and which panel is being sent because that tells you the genes that they're looking at. We can chat more after if you'd like. I think,
Well,
yeah.
let's try. So I just want to, yeah. Go ahead.
Go back to you.
Oh, sorry.
That's okay.
So when we're testing, we're looking for something completely different. And so we went from microarray to whole exome sequencing. Should I be talking to our geneticist to go back? Because the epilepsy gene was kind of caught by accident.
Okay, so whole exome sequencing is going to be looking at all of the genes that would be on any epilepsy panel. The only thing that you really sort of lose when you go to whole exome sequencing instead of a panel is that whole exome is looking at so many things. It's looking at each gene with a lower, it's called depth of coverage. So basically it's looking at every spot in the DNA code, usually about 10 or 20 times, whereas a lot of panels will be looking at every spot in each of those specific genes many more times than that. So they're looking at sort of a smaller set of genes, but with much more detail, as opposed to sort of a zoomed out approach with the whole exome.
So I think you kind of skipped over the next generation sequencing step, but that's okay because I think you got the information, and I don't think it would add a lot to go back to that test. Yeah. Did you want to answer?
One of the things that that you might want to talk to your doctor about doing is if they have specific genes in mind that they're suspicious about, to go to the lab and see how well those particular genes were covered. So they can go back and look and say, did we get a really good look at this gene, or do we need to go back and do some targeted testing to sort of fill in any blanks? Okay, there's a question down here.
My son had a microarray done like 7 or 8 years ago, and nothing since. And my question is, should we go back to what you just talked about?
The panel. Yeah, so I think, again, obviously it's different for every patient. There might be value in adding a panel onto the testing that he's had done. There also might be value in revisiting a microarray because that technology has actually improved a great deal in the past 10 years or so. So we can pick up things that a microarray 7, 8 years ago might have missed if it's a smaller.
Onus on parents to reach out to a hospital doctor, because what I thought was, the people that the doctors that discovered the gene, they contact they contact the patients.
Yeah.
And say, hey, you need to come down.
So sometimes, depending on what testing has been done and where it's been done, there will be instances that a researcher or that the lab will reach out to the person that ordered the testing and say, hey, we think we might see something new here. But I think the reality is that it often is on the families to follow up just because, we're seeing so many patients and the follow-up can sometimes fall through the cracks, unfortunately, when it comes to things like genetic testing. So I think I wish it wasn't the case that it was always on the families, and it's not always the case depending on the physician that you're working with, but I think it is a good thing to sort of touch base and say, we had genetic testing done a while ago, is it time to revisit that, see what else is out there?
And I think that, genetic testing is just like any other kind of test or treatment for epilepsy, right? So if you had, if this was 1995 and you had a head CT and MRI was just coming out, right, you would be like, well, my head CT didn't show anything, but that's not the best picture available. Mm-hmm. Maybe I need to get an MRI to look at the structure of the brain. Or, I went to the epilepsy doctor 2 years ago and these were the treatments that were available and none of them seemed to really be effective, but now 2 years have passed and there are more treatments available and I need to go back and revisit that. So I think usually when we see patients in neurogenetics clinic and we don't get an answer or we do testing and we don't find anything, we usually say 1 to 2 years is a good time frame to allow, kind of technology to catch up, to advance, and to allow enough time to lapse that it's worthwhile to look at those things again. So 7, 8 years, you're ready to go. Yeah. Yeah. Yeah.
And they tested us right away. We haven't gotten results yet. But the question is, how worried should we be that our older son might have the duplication? And if our
So I would say how concerned you have to be about your other child definitely depends on the results of your testing. If that testing comes back and shows that neither of you have that same duplication, it's very unlikely that your other son would have it. It's not 0%. There's something called germline mosaicism or gonadal mosaicism, where there can be a genetic change that's in the egg cells or in the sperm cells, but not in the rest of the body. So it depends on the specific gene, the specific condition, how common that is. But in general, we usually quote about a 1% risk that there could be something present that's not present in the rest of the parent's body.
Is there any value to the genetic test you can buy, you know, to buy with kids, just for other children?
I'll field that one.
Go for it.
So I would say direct-to-consumer testing, things like 23andMe and Ancestry. I think that there's value in the ancestry side of it if you're interested in that. That part of it I would say is quite accurate. When it comes to testing for different health conditions, it's not great testing. What those types of tests are doing is they're looking specifically at very common mutations in a handful of genes, but you're really only scratching the surface of genetic risks for cancers and cardiac conditions that those types of tests are screening for. So I kind of urge people, you know, if you're curious, that's fine. But if you're looking to really explore your own risks of having those sorts of conditions, if you have a strong family history of those sorts of conditions, it's definitely better to speak with a doctor about doing testing that's going to be more comprehensive and not just looking and kind of pinpointing very specific mutations. Any other questions?
All right, we got 3 minutes. Come on. Yeah.
So just to reconfirm, is there research going on with second and third generation? You know, do they have that type of research?
For
Types of epilepsy. For instance, I have it and my nephew, same family line,
yeah,
has the exact same
Yeah.
seizure, and
Yeah.
his daughter.
yeah.
So it's
Yeah, so there have been family studies. So the biggest one was out of New York, where they looked at, families with at least 5 members had epilepsy in that family. But again, it takes a lot of numbers because it sounds like not everybody in the family had seizures, right? So that means, again, it's going to be one of those smaller size gene effects. I don't know that there are any current family studies going on at the moment, but I think the information that we get about those smaller effect genes will probably play a lot into this type of epilepsy that your family has. Yeah.
I'm sorry, but I could not see the type.
I know,
Yeah,
it was
it
pretty
was
small,
tough.
we're sorry.
So, do you have a link or something that you grab that has the lists of sites?
I mean, we
So I
should.
think this talk was recorded today, so I think maybe the Epilepsy Awareness Day, we'll be able to post it somewhere, and then you can get it from that. We might want to talk to the people at the end. We can also go back if you, what were you looking at?
Just so that I'd be able to go back and grab some of this stuff.
Yeah, I guess if we want to go back to multiple things, I don't know.
Yeah, I think they should be able to share it one way or another with everyone that was here. So, yeah, we'll make sure that happens. Anybody else?
All right, well, thanks so much. Oh,
Oh.
one more.
Since we're just starting with the genetic testing, what is it, saliva, is it blood?
It depends on the test, it depends on the lab, but most labs at this point can do most of their tests on either sample.
What's the turnaround time?
Again, it depends largely on exactly what lab you're sending the testing to, but for panels, most of the time it's somewhere around 4 weeks.
And if your insurance is giving you a hard time,
I'll touch base with you
That's
after.
a
Yeah.
whole can of worms right
Yes, it
there.
is.
But oftentimes, you know, it depends on your policy, it depends on the hospital, and, you know, it depends on whether the doctor you're working with can, you know, do an additional review and send supporting documentation.
Depends on what kind of mood the insurance company is in that
Exactly.
day.
Many people still view genetic testing as experimental and not changing of treatments, even though that's really not the case any longer. So I think that's one of our biggest, you know, peeves.
Yep.
And so I think part of you know, what we need to do is kind of advocate again for accessibility for everyone to get that kind of testing.
All right, thanks so much for coming,
Thanks a lot.
everyone.